Good afternoon, everyone. I'm Dr. John Shrigley, the clinical lead for the Canadian Partnership Against Cancer's National Synoptic Pathology Project. On behalf of the Canadian Partnership Against Cancer and the Canadian Association of Pathologists, I would like to welcome you, everyone, to today's education session on the new CAP checklist for colorectal cancer with Dr. K. Washington. Before I introduce Dr. Washington and we get formally underway, I'd like to take care of a few housekeeping items. Today's presentation will be approximately 90 minutes in length and will include about 60 minutes of presentation time to be followed by 30 minutes of questions and answers. The session is being recorded and will be made available to all participants via email once the recording becomes available. Both the live presentation and the recorded presentation are eligible for CME credits upon electronic completion and submission of a pre-circulated evaluation forms to the following email address, pathology@partnershipagainstcancer.ca. Due to the large number of participants, we are unable to troubleshoot any WebEx connectivity issues as part of this call. If you are having difficulties accessing the WebEx portion of this teleconference, please call the WebEx support line at 1-866-229-3239. To pose a question for the speaker, I would ask you to use the chat section of the WebEx screen. For instructions on how to use the WebEx chat window, please refer to the documentation that was previously distributed. In order to avoid question collisions, I will pose the submitted questions to Dr. Washington on your behalf as long as time permits and in the order that they appear. Questions can be typed in at any time during the 90-minute teleconference. In the chat window, please include the following information: your institutional name, the name of the person posing the question, and finally your question. Thank you. It is now my pleasure to introduce Dr. K. Washington. Dr. Washington is a professor of pathology and director of the gastrointestinal and hepatic pathology at the Vanderbilt University Medical Center in Nashville, Tennessee. She's a graduate of the University of North Carolina School of Medicine and completed a residency at Duke University. Kay is very well known in the GI community. She's published extensively and has won numerous awards, and has also been an author of many book chapters, as well as doing a lot of very interesting research, and has a lot of grant money associated with her career as well. In particular, Dr. Washington has been involved in the College of American Pathology Cancer Committee for a number of years, and is now the new chair of the CAP Cancer Committee. Before that, she was in charge of the GI section of the protocol review panels. She's particularly noted for some of the protocols related to the GI malignancies, and is the senior author on a number of these publications, including, of course, the recently published colorectal cancer pathology CAP protocol, which came out in the fall of last year. Ladies and gentlemen, Dr. K. Washington.
Oh, thank you, Dr. Shrigley. That was a really glowing and very kind introduction. It's a little bit strange to sit in my office talking into a telephone here. I feel like I should have made my fellows come over so I have an audience. But at any rate, I'm delighted to be able to present this information to you, and I hope there are lots of questions and feedback on the protocols, because they really are a work in progress for us. My only financial disclosure is for a hepatitis B clinical trial in which I was the central pathology reviewer for Gilead Pharmaceuticals, and I have no financial disclosures related to colorectal cancer. I am a participant as a volunteer in the following organizations. As Dr. Shrigley points out, I'm chair of the Cancer Committee for the College of American Pathologists. I'm also a member representing CAP of the Commission on Cancer on the Executive Committee and other committees, and a member of the AJCC, American Joint Committee on Cancer. My objectives in doing this presentation are to provide a focused overview for you of changes to the CAP colorectal cancer checklist, and present the data driving these changes in context of changes to the AJCC TNM Staging Manual 7th edition. And I really do want to solicit your feedback and questions on this document. The CAP cancer checklists were developed as part of a multidisciplinary effort spearheaded by pathologists, but with input from medical oncologists, surgical oncologists, radiation oncologists, et cetera, on the review panels. The overall goal is to improve patient care by standardizing the quality of our surgical pathology reports for cancer resection specimens. And by improving our reporting capabilities, we also drive research, especially in the population sciences field, and improve reporting to cancer registrars. There are a number of organizations, as you see in this part of the arrow, that have contributed to development of the checklist as well. This diagram just shows you some of the relationship between the organizations that are involved in the checklist. Of course, the checklists are developed by the College of American Pathologists, who this organization is also a founding AJCC organization. And the checklists are used by the Commission on Cancer as part of their evaluation of the quality of cancer care in various cancer programs that they accredit, which are now about 1,400 U.S. cancer programs. About 70% of the cancer patients seen in the United States are taken care of in COC-accredited programs. And the COC houses the National Cancer Database, which is a large repository now of cancer-related data. And these data are used by the AJCC in developing and changing their staging systems. And, of course, AJCC also cooperates with the UICC for global cancer staging. But my focus today is to talk about the changes to the CAP colorectal carcinoma checklist and put that in context of the changes to the 7th edition of the AJCC staging manual. There have been, in fairness, criticisms of the CAP colorectal checklist and of the AJCC, particularly the 6th edition of the staging manual. And I draw your attention to this article by Phil Quirk, a pathologist in the United Kingdom, who published in Lancet in 2008 a number of concerns about the process by which these systems are changed. He, in particular, points out that changes in T&M system lead to the inability to compare results of new clinical trials with old, and charges that some of the changes are based on postulation and not necessarily on adequate evidence. And I think that we can agree that more transparency about the revision process is needed, although I believe AJCC is working to address some of these concerns. Pathologists are, of course, a very important team member in care of the patient, the cancer patient. Our assessment of the extent of disease remains the gold standard for T&M staging. And what we report in our surgical pathology reports does have a tremendous impact on the decision to give the patient adjuvant therapy or not. In addition, of course, we report a number of prognostic factors, and we provide quality control data for surgery and radiology. So nothing can diminish the importance of our input. However, there are some controversies and difficulties in this pathologic assessment. It is, as most things we do in anatomic pathology, subjective to a certain degree. And hence, I believe the need for standardized examination protocols and for standardized reporting. Current terminology has, in some instances, caused confusion. I don't think we're out of those woods yet, but we are trying to address some of these ambiguities. And any standardized system we have really should be evidence-based. But in some areas, the data are often limited, and we have to admit there are sometimes gaps between recommendations and reality. Now, as we go through the presentation, anytime you see this logo with a check mark, I'm going to be talking about one of the elements of the checklist. And at this point, I'm just going to start going through the colorectal checklist for resections, including transanal excision. And the checklist starts out with the specimen that you receive, the procedure, and the tumor site. We do ask that you continue to report tumor size, although this is a little bit controversial, believe it or not, because tumor size really does not have much impact on outcome in colorectal cancer. So it is reported mainly as a matter of convention. I believe it's easier to just go ahead and report tumor size for solid tumors than it is to try to remember when you really need to report it and when you don't for staging purposes. But tumor size is not one of the elements of the T category for the T&M system for colorectal cancer. The next item of interest on the checklist is macroscopic tumor perforation, and I borrowed this photograph from pathguy.com. I think it's a great illustration of perforated colorectal cancer, where you can see this gross extension of the tumor through the wall of the colon and the gaping perforation here. And this is an especially poor prognostic sign, automatically results in the tumor being assigned a PT4 and should be reported if present. If the colon has perforated proximal to an obstructing tumor, that is not perforation through the tumor, but you should report that in the comments section. Those patients, even though their tumor has not perforated, often have a very poor outcome because of sepsis and peritonitis and postoperative complications. These pictures of the mesorectum, I want to point out, are from an absolutely fantastic website on assessment of mesorectal excision from the University of Alberta, and the photographs are really outstanding, and I would urge you to check out this website. But the next item that we need to talk about is the macroscopic intactness of the mesorectum, and this is an optional item. Many pathologists are not reporting this, although we are being asked to more and more by either our local institutions or as recommended for care of the cancer patient. This applies only to rectal carcinomas, and basically for surgeons trained in total excision of the mesorectum, there is a much lower local recurrence rate, usually less than 7%, compared to those who have not been trained to perform mesorectal excision, in which the local recurrence rate is 25 to 40%. So this has a tremendous impact on local recurrence and patient outcome. And it is graded as complete, near complete, or incomplete. And the photograph I'm showing you here is a good example of complete mesorectal excision. And you'll note that there's no coning of the specimen as we move towards the anal end of the specimen. It doesn't cone down to a point. The mesorectum appears very smooth with only some wispy strands of fibrous tissue on the surface, and the posterior surface shows intact what has sometimes been called the mesorectal buttocks, these rather bulging areas here. The anterior surface, likewise, is very smooth, and there are no clefts in it. And these particular rules were developed by Dr. Quirk for assessing the mesorectum, and basically one should see a very smooth mesorectum as we've described, with only minor irregularities, and no defect should be deeper than 5 millimeters, no coning. And if you do cross-sections of the specimen, you should see a smooth circumferential margin. Near complete, you can have some irregularities of the mesorectal surface, a little bit of coning, but you should not be able to see the muscularis propria anywhere from examining the external aspect of the specimen. And incomplete mesorectal excisions have very little bulk to the mesorectum, severe defects down to the muscularis propria, and a very irregular margin of cross-sectioning. So I would recommend just remembering 3 basic rules: a bulky mesorectum with a smooth surface, no clefts deeper than 5 millimeters, and essentially no coning for the complete mesorectal excision. But as I've stated, this is still optional for the checklist at this time. The next checklist element is one that I think people don't generally have problems with at all. It's determination of the histologic type. And we've listed some of the more common types of colorectal cancer histology that you see, but by no means all of them, but this should encompass most of the elements seen in practice. And you'll notice that on the photograph is of a very typical colorectal cancer, and I would say that close to 90% or so of colon cancers look like this. A gland-forming carcinoma, adenocarcinoma, not otherwise specified, and about usually moderately differentiated. These are some of the other subtypes that we see. The medullary carcinoma, in particular, I think people have a little bit difficulty recognizing because it's so rare. It's about 1% of colorectal cancers. The signet ring cell carcinoma we are more familiar with from gastric cancer and easily recognized. Neuroendocrine carcinoma often requires special stains to sort out because, as you can see, there can be some overlap with the medullary carcinoma. Grading is a source of confusion for some pathologists because the checklist recommends a two-tiered grading system. Most of us in practice use a four-tiered grading system, well-differentiated, moderately differentiated, poorly differentiated, and undifferentiated. And it's actually fine to use the system that you're accustomed to using. You can modify the checklist to accommodate such things as your favorite grading system. But because there are differences in observer variability with pathologists, we recommend a low versus high grade grading system for reporting purposes. Grades 1 and 2 would be lumped into the low grade, grades 3 and 4 into the high grade for those purposes. In grade 1, you can see that it's a tubular forming cancer, all gland forming essentially. Grade 2, at least 50% gland forming. Grade 3, less than 50%. And grade 4, essentially no glands in the histologic field. Now, one element recently added to the checklist is that we're asking pathologists to look for histologic features suggestive of high levels of microsatellite instability. And the ones we're specifically looking for are intratumoral lymphocytes as assessed on the H&E stain, the peritumoral lymphocytic response, or the so-called Crohn's-like reaction beneath the tumor, and to consider the tumor subtype and differentiation as an element that may suggest microsatellite instability. And why are we doing this? Well, as you know, there are two major pathways in the carcinogenesis of colorectal cancer. The more common is the chromosomal instability pathway, in which mutations in the HPC gene, either germline and familial adenomatous polyposis coli, or sporadic in most of the cases, is the driving force behind the cancer. However, about 15% of colorectal cancers use the microsatellite instability pathway, and about 2 to 3% overall are Lynch syndrome patients, in which the patient has a germline mutation in a mismatch repair gene that leads to an inherited susceptibility to colorectal cancer, among other tumors. But most microsatellite instability high tumors are admittedly sporadic, and they're due to epigenetic silencing of the MLH1 promoter by hypermethylation. And most of these cancers occur in older people. But we want to be able to identify the patients with Lynch syndrome, and we may need to identify the patients with sporadic MSI-high cancers because they may not respond as well to 5-FU-based chemotherapy, and because they have a better outcome, it may not be necessary to treat them anyway. So, getting back to Lynch syndrome, these are patients who have early age of onset of right-sided colon cancers, and they have a tendency to develop multiple cancers, in particular endometrial cancer, and small bowel cancer is also notable. The identification right now of a patient relies on the family history to pinpoint patients needing genetic testing. And you can see that overall, the Lynch syndrome patients have a very high lifetime risk of developing colorectal cancer compared to the general population, and a quite high risk of about 60% of developing endometrial carcinoma. So it's important to identify these patients so they can be screened appropriately for these cancers. This is an autosomal dominant disorder, and the basis for it is germline mutation in one of the mismatch repair genes, usually MSH2 or MLH1, less often one of the PMS genes. And these mutations lead to instability in microsatellites, which are short repeat sequences of DNA found throughout the genome. And while the microsatellite length varies from individual to individual within an individual, it's remarkably stable normally. But in the tumor, you can see that the microsatellite length becomes quite variable, and hence the designation microsatellite instability. As I've said before, the rationale for reflex testing of colorectal cancers is that detection of this mismatch repair deficiency could potentially serve three roles. Prognostic marker of survival. Microsatellite instability high cancers tend to be less aggressive overall. As we said, they may not respond to 5-FU-based chemotherapy, and we do need to screen for Lynch syndrome. But the exact clinical benefit, especially as a prognostic marker and predictive marker, has not been quantified, and it's standard of care currently to only search for microsatellite instability when you suspect Lynch syndrome. But a lot of this is based on your local institution and the requests of your oncology colleagues. Many institutions follow the revised Bethesda guidelines for testing for Lynch syndrome, which would advocate testing in any patient who has a colorectal cancer diagnosed before age 50, patients with synchronous cancers. But the one I want to highlight for you is colorectal cancer with features of MSI-H before age 60, and hence the inclusion in the checklist of some of the features of microsatellite instability high tumors. Most chromosomal instability tumors, the sporadic tumors, have dirty necrosis. And when you see that, it's less likely to be MSI-H, but it doesn't exclude it entirely. Microsatellite instability high tumors are often mucinous. This is the most common subtype in that group, and even up to 2/3 of them have some mucinous histology, hence the request to report any degree of mucinous histology as a feature that may indicate microsatellite instability. The Crohn's-like lymphocytic reaction is often very pronounced in these tumors. Here you see a collection of lymphocytes beneath the leading edge of a medullary-type carcinoma, and numerous tumor-infiltrating lymphocytes are a very suggestive feature of high levels of microsatellite instability. We're not advocating that people do immunohistochemistry for T-cell markers to bring these out, but rather to just assess them on the H&E. And how good is morphology in distinguishing MSI-H from stable tumors? If you look at a combination of features, it's actually better. But here's some data from two cooperative group studies that compared 92 microsatellite instability high tumors with 231 that were stable. And you can see that the medullary carcinomas, mucinous signet renal cell carcinomas, made up a fair percentage of the MSI-H tumors, and almost half of them had the Crohn's-like reaction, but that didn't help that much because we also saw that in the microsatellite stable tumors as well. But the medullary tumor appearance has a very high odds ratio, very high likelihood of being an MSI-H cancer. If we combine some of these features, as Joel Greenson and his colleagues did in a paper they published several years ago, we get a very high sensitivity and negative predictive value, but specificity is not great. So the combination of numerous tumor-infiltrating lymphocytes, no dirty necrosis, and mucinous areas in the tumor does give you a very high sensitivity for detecting MSI-H tumors and referring that case for further molecular testing or for immunohistochemistry. Now, moving on through the checklist, the next element is microscopic tumor extension. And this section of the checklist just asks you to report how deeply into the bowel wall the tumor has invaded. And I think not many changes from the previous checklist, so I won't spend a lot of time on this point, but feel free to ask questions if there's something that I haven't covered when we get to the end of the session. I'd like to point out that this diagram from the NCI is a little bit optimistic in that it has the lymph nodes sitting outside the serosal layer, and I think our residents would all love it if the lymph nodes were sitting there just ready to be plucked, but a little bit of an oversight when the drawing was made. Before we get into some of the other elements of the checklist, I think we need to consider the anatomy of the colon, because we're going to talk about margin assessment, and that always gives people some problems when we talk about circumferential margin. I think the problem is we don't have a great terminology for these areas of the colon that are covered by peritoneum and have a mesenteric pedicle. And we call that mesenteric pedicle margin the circumferential or radial margin, just as we do the rectal circumferential margin. So it's worth bearing in mind the areas of the colon that are fully invested by peritoneum and only have a mesenteric pedicle, or the cecum, the transverse colon, and the sigmoid colon. This circumferential or radial margin refers to a soft tissue margin, and as I said, it's pertinent to the mesenteric pedicle, the rectum circumferentially. The right colon and left colon have bare areas on the posterior that are retroperitoneal. We don't refer to the serosal surface as a margin, but that does get factored into the T category. And this is just an illustration of where we would assess the circumferential margin. In the cecum, the transverse colon, and the sigmoid, our mesenteric pedicle would be the circumferential or radial margin. In the ascending and descending colon, we would have a bare area that's retroperitoneal that constitutes the margin, and the rectum, because it's entirely outside the peritoneal covering, has a true circumferential or radial margin. And this leads to a little bit of confusion when we're evaluating the rectum, because we can have the situation where the tumor extends entirely through the specimen, involves the dissected surface of this margin, and the tendency is to want to call it a T4 lesion. But remember, there's no serosa in most of the rectum, only up at the very proximal most end of the rectum could you have any peritoneal covering. And so generally this is a T3 lesion into the perirectal fat with margin positivity. However, in areas of the colon that are invested by visceral peritoneum, this would be a T4 lesion if it penetrated the serosal surface. And here's an example of radial margin in rectal cancer. These transverse sections are very nice for illustrating the positive margin here as the tumor goes to the dissected surface. So this would be a positive radial margin and would constitute T3 disease with positive margin and not T4. So moving on through the checklist, the next item, which is a new element, is tumor regression grade. And again, this applies primarily to rectal cancer. And the general rules are that it should be assessed only in the primary tumor. The lymph node metastases should not be included in the assessment. And a question that comes up quite frequently is, how do you assess acellular pools of mucin in specimens from patients receiving neoadjuvant therapy? These represent completely eradicated tumor, and they're not used to assign the P stage or counted as positive lymph nodes. So if you see only a few histiocytes in there and you don't see tumor cells, then that represents completely eradicated tumor. And the elements on the checklist are in this particular format. And there is no single agreed upon tumor regression grade scheme. We chose one from the literature that was used by several publications, but there's certainly room for improvement on some of these, I think. And the AJCC has included this as part of their data collection as well. So for the AJCC TNM7, this is the scheme that was chosen. And basically, if there are no viable cancer cells, that is given a regression grade of 0. If they're single cells or small groups of cancer cells, that's considered moderate response. If there's some residual cancer, but mostly fibrosis, but more than single cells or small groups of cancer cells, minimal response. And a poor response, or grade 3, would be when you really can't tell that the tumor has had treatment. And here are some examples of those tumor regression grades. So a grade 3 shows abundant viable tumor, some necrosis, but still very obvious viable tumor. Grade 2, you can see in this example, is more fibrous tissue than tumor remaining, so a moderate response. Grade 1, a few clusters and single tumor cells, and grade 0, completely eradicated tumor with acellular pools of mucin. The next item on the checklist is lymphovascular invasion, and this element has repeatedly been demonstrated to be significant by multivariate analysis. Some studies have shown venous invasion to be more important and some lymphatic, and the old checklist distinguished between the two, but the new checklist no longer does so. I think we're doing well if we can agree on lymphovascular invasion regardless of whether it's small or large vessel. The problems come in interpretation, as there is a great deal of inter-observer variability among pathologists. We haven't found special stains to be terribly helpful, but some people advocate use of elastin stain. And for the colon, we really haven't agreed upon minimal criteria. Here's an example of small vessel or lymphatic invasion, tumors present in an endothelial line channel, no smooth muscle in the vessel wall. And here's some examples of large vessel invasion, which represent invasion of veins. You can see in the figure on the right, there's an artery down at the bottom of the field, and the tumor present in what is likely a vein above it, and a large vessel in the photograph on the left as well. Several years ago, my GI pathology fellow and I did a study where we looked at inter-observer variability for large and small vessel invasion in colorectal cancer. And we had 6 GI pathologists, 50 stage 2 cases, and all 6 pathologists agreed on exactly 2 out of 50 cases. And you can see our kappa values were not great, and for small vessel invasion, we really did not improve with either use of CD31 or D240 for lymphatic channels. We did improve somewhat with using CD31 for large vessel invasion. But it just points out some of the difficulties in assessing lymphovascular invasion. We chose to put perineural invasion in the colorectal cancer checklist because emerging evidence indicates that this is actually a very strong indicator of aggressive tumor behavior. It's pretty uncommon. It's found in less than 10% of cases. In the large series of cases we looked at here, we found it in 58 out of over 700 cases of colorectal cancer. And when you find it, it's generally associated with high tumor grade and stage with a higher relative risk of death from disease. Most of the studies analyze a relatively small number of cases and their retrospective studies, but there's a new study that I want to highlight for you that just appeared in late 2009 in the Journal of Clinical Oncology. And this group looked at perineural invasion and its impact on disease-free and overall survival in a cohort of cancer patients. And you can see that there was a significant decrease in disease-free and overall survival in the cases with perineural invasion. And when you looked at margin-negative resections, you also got the same effect as well. So it appears that perineural invasion is a quite powerful prognostic factor. One item in the checklist I want to spend a little bit of time on is this issue of tumor deposits, because this is new to the AJCC TNM for colorectal cancer, and it's creating some confusion as we move towards reporting these uniformly. These tumor deposits are discrete tumor deposits in the pericolonic or perirectal fat. They're discontinuous with the bulk of the tumor, and they should be in the lymphatic drainage of the tumor. If they're outside the lymphatic drainage of the tumor, then they're considered to be metastatic disease. And one should not find evidence of residual lymph node tissue. And the reason for the interest in these pericolonic or perirectal tumor deposits is that they may be similar to melanoma in transit. There are some papers that suggest that this is a very aggressive feature. And the problem comes in as to how should these be factored into the staging system. There are even some individuals who advocate that they should be considered equivalent to metastatic disease. Most of us are not there yet, but we do agree that they are probably an aggressive feature. I think all of us could recognize the lymph node on the left as harboring a lymph node metastasis. I think there would be possibly some disagreement about the lesion on the right. Is that a peritoneal deposit or a lymph node metastasis? And the crux of the matter is, are you convinced that there's residual lymph node tissue there? If so, then you can count it as a lymph node metastasis. If not, it should be counted as a peritoneal deposit. And here's an example of an irregular peritoneal deposit, which probably represents invasion of a small vein. You can see the artery here, and I expect this represents venous invasion. But how do we handle these? Well, the AJCC 4th edition designated tumor along a named artery as N3, but that category was removed from the 5th edition. The 5th edition used a cutoff of size. If the deposit was 3 millimeters or less, it was called an extramural tumor deposit. If it was greater than 3 millimeters, it was called a replaced lymph node. But there was no data to support this, and it was changed in the 6th edition when the designation was based on contour. So if you had something with a round, smooth contour, you called it a completely replaced lymph node. And if you had a lesion with an irregular contour in the fat, you called it venous invasion. But this led to problems with tumors otherwise classified as PT1 or PT2, and you could have a stage 1 cancer with these deposits and negative lymph nodes the patient would not be given adjuvant therapy. And so there was a disconnect between how we were staging these patients and how the oncologist thought they should be treated. These graphs are from a paper by Dr. Pupa from Italy that was published in Modern Pathology, and he did a very detailed examination of peritoneal deposits and classified them as with or without lymphocytes. But the feature I want to point out to you is how survival drops off significantly with these peritoneal deposits compared to lesions without them in stage 3 cases. So we think that they are a marker of very aggressive disease, whether they represent lymphovascular spread or totally replaced lymph nodes. Now, the 7th edition of the TNM is designed to collect the data on these tumor deposits. And if you see a tumor nodule in the pericolonic fat without histologic evidence of residual lymph node tissue, then it's classified as one of these deposits. And in the absence of unequivocal lymph node metastases, these are recorded as N1C in the N category. And that results in these lesions being categorized as stage 3 disease, which are typically treated with adjuvant therapy. Previously, I'll go back. There was basically inconsistency in how people were staging these cases. When I saw them and I didn't see them in a lymph node, then I considered that T3 disease usually. But the medical oncologists, when these were reported to them, wanted to consider them as metastatic lymph nodes. So there was a discrepancy in the staging, which this particular classification is designed to correct. And the idea is that we should report the number of these tumor deposits regardless of the T stage of the lesion and regardless of the other N categories. So the data will be there to inform the next edition of the TNM staging system. So the major changes in TNM7 for the pathologist are that the old T4A and T4B designations are flipped. The new N1C category has been created for peritumoral deposits in which you don't have positive lymph nodes. And N1 and N2 categories have been broken down, and the M category has also been subdivided. And these changes were made on the basis of data from the NCDB. Just to show you briefly the old TNM staging system for the 6th edition, it was pretty simple. We did have some subdivisions in stage 2 and stage 3, but basically fairly simple. And this staging system served us well. You can see there is a difference in the survival curves for stage 1, 2, 3, and 4 disease. But when you start looking at the subcategories, a problem emerged in which patients with T4 or tumor on the serosal surface or invading adjacent organs, but with negative lymph nodes, actually did worse than some patients with positive lymph nodes. The new staging system is much more complicated in the stage groupings, and I don't want to go through them in any detail because that's not really our job. Our job is to determine the T, N, and M categories as best we can from the specimen and report other prognostic features. The T category elements that give people some problems are the carcinoma in situ category, because we don't usually use that terminology in GI carcinomas, and we'll talk a little bit about that. And when we flipped the T4A and B categories, that created some confusion. But basically, based on new data that suggests that tumor directly invading other organs has a worse outcome than tumor penetrating the visceral peritoneum, the T4A and B categories were reversed. Now, carcinoma in situ is not a term that GI pathologists use for glandular epithelium, but for reporting purposes, the AJCC includes this terminology. Now, whether you have to report cases with intramucosal carcinoma and a polyp is a matter of local reporting requirements. Personally, we don't report cases of polyps with high-grade dysplasia as carcinoma in our system, but there are state and local laws that do govern this. But for definitional purposes, carcinoma in situ, T category for AJCC includes what we would call high-grade dysplasia, cancer cells confined within the glandular basement membrane, or what we would call intramucosal carcinoma, in which the tumor cells infiltrate the lamina propria but do not penetrate into the submucosa of the colon. And these are considered both carcinoma in situ for the colon because there is essentially no chance of lymph node metastases and spread from these tumors. As we've said, the T categories have changed in the AJCC 7th edition for T4A and B, and we'll talk about that in a little more detail. These are just examples of T categories. T1, tumor invades the submucosa. You can see here the muscularity cozy, and it's disrupted here. The specimen is a little bit buckled as the tumor invades through it. So tumor into the submucosa remains T1. T2 in the 7th edition is tumor invasive into the muscularis propria. No changes there. T3 is not subdivided, as some have advocated, in the AJCC 7th edition because it's not clear how much additional information you gain by subdividing T3. So a lesion like this, in which tumor is barely invasive into the pericolic fat, is a T3, as is the one on the right, which is a more deeply invasive tumor. And T4A is tumor present on the serosal surface. And this can be a little bit difficult to assess, and I think that we are underreporting this serosal surface or local peritoneal involvement. And when you're grossing in a specimen, look at the clefts on the serosal surface near the tumor. And the tumor is often invading in one of these little clefts or between fibrous adhesions in the specimen. And you can see here microscopically the tumor has eroded through the peritoneal lining, and there's actually tumor floating free here in this in this cleft-like space. Same thing going on here. T4B is invasion of local organs, and here's an example of a tumor invading a fallopian tube as a T4B lesion. Tumors can be classified as T4B on the basis of clinical adherence to the organ, but if you see a fibrovascular adhesion that does not contain tumor microscopically, but tumor is nearby, then that would remain, in this case, it's actually a T2 lesion. So while clinicians may categorize something as a clinical T4, the pathologic examination will trump that if the adhesion is negative for tumor. But getting back to this local peritoneal involvement, there's difference of opinion as to whether if you have tumor near a serosal surface but with a mesothelial reaction, should that count as a positive serosal involvement? And most pathologists reserve the T4 category, T4A, for lesions with tumor at the serosal surface, and you usually do see an inflammatory reaction. So if you just have tumor nearby, it's probably less important, but you may wish to report that. And there's a difference of opinion, but most pathologists err on the side of being conservative here. So tumor at the serosal surface or free tumor cells on the serosal surface with underlying ulceration of the visceral peritoneum. And this finding is associated with palliative surgery, high tumor grade, other high-risk features. The data that were used to support flipping the T4A and B categories comes from the National Cancer Database and the SEER database. And you can see that for node-negative and node-positive tumors, cases with serosal involvement had a higher 5-year survival compared to those with invasion of adjacent organs, hence the decision to reverse T4A and B. Moving on to lymph node issues, the number of lymph nodes needed to accurately stage the specimen always comes up as an item of discussion in colorectal cancer staging for pathologists. And there are a number of papers out there looking at how many lymph nodes do you need to find to accurately assess stage 3 disease. And the one that's quoted most often is this Scott paper from 1989, in which they recommended that at least 13 lymph nodes be found. But it really varies from at least 12 to as many as possible, or at least 30. But we have to strike a happy mean here and come up with a realistic number for people that does accurately stage patients. There's another issue in finding lymph nodes in colorectal cancer as well. Even if the lymph nodes are negative, multiple studies have found there's a survival advantage when more lymph nodes are identified. And this is probably a surrogate marker for an immune reaction to the tumor. But there's an interesting paper by Joseph that found a much higher 5-year survival when you found at least 30 lymph nodes. And there are multiple studies that support the number of lymph nodes as a stage-independent prognostic factor. And data for the TNM 7th edition supports these findings as well. When you look at the in-classifications for T3 colon cancers, based on over 170,000 patients from the SEER database, you can see that the overall survival goes up even when you have positive lymph nodes, the more lymph nodes you find. So that is also why we recommend finding the largest number of lymph nodes that you can. How well are we doing? Well, historically we haven't done that well, although I think we're doing better as this is now a quality improvement measure in a number of institutions. And you can see these data from the SEER database from 2005, in which most institutions did not find the recommended 12 to 15 lymph nodes. But we are doing better. There was a really interesting paper out just last year that suggests that the number of lymph nodes we need to find really depends on the T stage of the tumor. So for a thin lesion, a T1 tumor, you probably don't need to find as many lymph nodes as you do for a T3 or T4, in which you may really need to find close to 30 lymph nodes for a T4 cancer to make sure it really is a stage 2. So I think we'll be seeing some more interesting studies on that. For the 7th edition of AJCC, the PM category has been subdivided into M1A and M1B based on whether there's a single organ site or more than one organ site involved. But I want to point out that PM0 is not a choice on the checklist because it implies absence of detectable metastases anywhere in the body, and we really shouldn't be using it for resection specimens. And there are some people who believe it should not be used for autopsies either. Autopsy has its own A designation, so it would be AM0 for an autopsy. And the use of PMX has been entirely discontinued by the AJCC. The checklist also contains some optional items for ancillary studies, and these include immunohistochemistry for mismatch repair proteins, mutational analysis for BRAF, and mutational analysis for KRAS. And these are applicable in some situations, but certainly not all. You may choose to do immunohistochemistry to identify microsatellite instability high tumors, and these can be a little tricky to interpret. Basically, if you see nuclear staining in the tumor, that means that protein is present, and there is no evidence of mismatch repair deficiency if all of the proteins tested are present. This helps direct gene testing by predicting the likely involved gene if you do find loss of one of these proteins. And if you have abnormal immunohistochemistry, most people will proceed to some kind of genetic testing. One thing that has emerged in the past year or so is the analysis for KRAS mutation, which is found in 40% of colon cancers. And patients who have KRAS mutant tumors may not respond, essentially won't respond to anti-EGFR drugs such as cetuximab. And so most institutions are testing patients with stage 4 cancers and in some cases very high risk stage 3 cancers. There is some evidence, these curves just show you that there is essentially no change in survival when you treat a patient with mutated KRAS with cetuximab compared to best supportive care, but there is a significant overall survival when the patient has wild-type KRAS. There is some data to suggest that BRAF mutation and KRAS mutation do have some impact on overall survival, independent of treatment, in that they do have a little bit worse outcome, but we don't see it in the progression-free survival, but rather in the overall survival. So I want to finish at this point, and then we'll take questions just with a take-home message. As Carolyn Compton likes to say, the pathologic assessment of TNM is the triumph of low-tech. And it is a very high-impact, cost-effective method for prognosis, widely applicable. And the CAP checklist and the synoptic format are there to help us achieve uniformity in assessment and reporting. So hence their utility in colorectal cancer, and we've tried to tailor the new colon checklist to the important elements that are going to be used in deciding patient treatment. Some of the optional elements especially are designed to help us collect data that will allow for improved staging and prognostication in the next edition of the TNM-8. And I think it's clear by the time that 8th edition rolls out, molecular profiling will be providing more key predictive information, but we do need more data before we can incorporate those into the staging and prognostic systems. And I'd just like to thank Dr. Strigley for asking me to do this, and to acknowledge Dr. David Page, who has been my mentor at Vanderbilt and a longtime member of the Cancer Committee for CAP in the past. And Carolyn Compton, of course, is the driving force behind the colorectal cancer checklist, and you see various staff members listed there who have also been very helpful. So I'll stop at this point and see if Dr. Strigley has any questions for us.
Thank you very much, Kay, for a very clear presentation. We do have some questions rolling in as I'm speaking. The first question is from Dr. Shull in Toronto. If you have a T2 tumor with a single mesenteric tumor deposit and 3 possible lymph nodes, is it T1N1B, T1N1C, or T1N1D?
Okay, so we have a T2 tumor with a single tumor deposit and positive lymph nodes?
Yes, go back for a second. Yeah, it's a single mesenteric tumor deposit and 3 possible lymph nodes.
Possible.
Yeah.
Well, there are some ambiguities in this AJCC chapter that we're struggling with right now, and actually Carolyn Compton and I are set to talk about this issue on Friday, but we've had numerous emails back and forth about it. So my advice to pathologists is to use your judgment about whether you think something is a positive lymph node. We can't come up with strict guidelines for every possible scenario here. But if you think something's a positive lymph node, go ahead and count it as such. Just count up what you think are tumor deposits where you can't absolutely swear to it being a lymph node. Now, the good news is, no matter whether you call it a positive lymph node or peritumoral deposit, that's still going to count as the N1 category at least. And the stage groupings don't separate out N1C from the other N, so it would be staged as stage 3 for treatment purposes regardless. And I think that is an improvement, but it does give us some problems in assessing these tumor deposits.
Okay, there's a number of questions regarding these lymph nodes and peritumoral deposits. Here's another one here. How would you classify the PN if there are peritumoral deposits and if there are also greater than 3 involved lymph nodes?
Okay, the involved lymph nodes would trump the peritumoral deposits. Okay. So if you had greater than 3 positive lymph nodes, that would put you into the N2 category. And that would trump it for staging purposes. The peritumoral deposits would still be reported on the AJCC form for data collection purposes. I think one of the ideas behind separating out the peritumoral deposits really pertains to the thin lesions, the T1 and T2 lesions with negative lymph nodes, and these tumoral deposits, because we're really uncertain as to the impact of the tumoral deposits. We think it will be greater on the outcome in the thin lesions, because a T3 tumor is already at higher risk, obviously, than T1 or T2, so the effect may be less. But, yeah, if you have positive lymph nodes, unequivocal positive lymph nodes, then that nodal category trumps the N1C.
Here's another question. This is from Kelowna General Hospital in BC. Does an involved lymph node located 1 millimeter from the circumferential margin change the T category?
Change the T category.
T category.
No, it would not change the T category. Whether it changes whether you would report that as a positive margin or not, the AJCC is asking us to report in millimeters distance of tumor from margins, from radial margins for recording purposes. And I know there are pathologists who consider tumor within 1 millimeter as a positive margin. Again, that's a matter of debate among some pathologists. Many people want to hold out for seeing tumor cells in the margin proper, not just within a millimeter before they'll call it positive, but the AJCC is trying to collect data on these very close margins to make a definitive call on it.
Here's a call from Lori Russell. How do you report the TT stage if the tumor is 1 to 2 millimeters close to the serosal surface?
I call that a T3, personally, and I comment on how close it is to the surface. And it may be that in some cases we need to do additional sections on those cases. It would really depend. How aggressively I pursued that would depend on whether there were nodal metastases. Obviously, if you've got a lot of positive lymph nodes, that puts the patient in a very high-risk category, and it may not be worthwhile just to chase a T4, but if you've got an otherwise, if you've got like a T3, N0, and no tumor deposits, then that, to establish it at work, a T4 lesion will put the patient in a higher risk category. So I might do step sections in that case to make absolutely sure, or go back and put in more tumor sections.
Another case, if there are 8 positive lymph nodes, then do you still proceed to retrieve at least 12 lymph nodes?
That's the recommendation, and it is based on what part of that, from our point of view here, is we're trying to teach residents how to retrieve lymph nodes. So we want to use every chance we have in teaching them to retrieve the optimal number. And we also want to maintain credibility with our colorectal surgeons, who will bounce a report back like that to us if the patient hasn't had neoadjuvant therapy. And I think for reporting purposes, we want to hit at least the 12 lymph node standard, and because of the potential impact on patient outcome. In our institution, the oncologists sometimes regard a case with negative lymph nodes, well, this would have 8 lymph nodes positive, so it's not relevant. But if you have negative lymph nodes and fewer than those typically found, they will regard that as essentially a lymph node positive patient, even though the staging rules don't support that. But I think 8 positive lymph nodes, we would be doing it to assess this weaker impact on prognosis of the number of lymph nodes you find, and to maintain credibility with our surgical colleagues.
Here's a question from Kelowna General Hospital. What is the significance of a left-sided tumor's location relative to the A, rectosigmoid junction, and B, anterior peritoneal reflection?
Well, I'm not quite sure I totally understand the question. I guess it would relate to, is it a high rectal versus a low sigmoid cancer, and the reporting requirements there. So I'm looking at the checklist, and I don't see a real difference in the checklist tumor sites as listed. So I think it would apply mostly for reporting purposes.
Okay, another question regarding number of tumor deposits in N1C category should be included in the total number examined / positive count as the header is regional lymph nodes status category. I guess where does that belong?
Where do the tumor deposits belong?
Yeah.
Well, on the checklist, let's see, I'm looking at our checklist now. There is the tumor deposits is basically not identified, present, and indeterminate. And really, we should have an area to report the number found. So that's probably a change that needs to be made to the checklist. If you have your AJCC staging manual, they do have the staging forms for colorectal cancer. And I'm turning to that now so I can direct you to it. There is, on page 162 of the AJCC staging manual, a grayed-in box that says prognostic factors, site-specific factors, and it has a blank for tumor deposits in which you're supposed to record the number found. So that is one change we could certainly make to the checklist to include specific instructions to record the number.
Okay, we have another question. This question is from Dr. Al Haddad, St. Michael's Hospital, Toronto. How do we stage tumor going down a diverticulum? Does it change the stage of the main tumor as T2 and the diverticulum when it's going into fat? Does it change the stage if the main tumor is T2 and the diverticulum is going into fat?
If the tumor is making its way outside the muscularis propria, whether it's diverticulum, in the diverticulum, or in the main tumor, I would still stage this a PT3. You know, PT3 is a continuum. We've chosen not to have these subdivisions in the T&M, which I'm glad, because I hate to make people measure things. I think we're asking a lot of our pathologists already for cancer cases, but certainly a T3 tumor that's just a little bit outside the muscularis propria into fat is probably closer in behavior to a PT2 than it is to a PT4. But I would still record it as a T3 if it invades the pericolonic fat, even if it's coming through a diverticulum.
Okay, another question from Dr. Wren. If a lymph node is involved directly adjacent to or within tumor, is it metastasis or is it direct extension?
This comes up all the time in multiple organ systems, and the AJCC general staging rules address this, and this is always recorded as positive lymph nodes, even though biologically it may not be the same as a true lymph node metastasis. The AJCC doesn't distinguish between direct invasion and spread through lymphatic channels to lymph nodes, but counts them all as positive lymph nodes. And this is, of course, probably the way you get nodal positivity in sarcomas, for instance.
Okay, another question. This question is regarding necrotic nodules. Necrotic nodules without viable tumor cells, how should they be interpreted pre-treatment or post-treatment?
Pre-treatment, I've only seen a few cases like that, but it's really difficult. And I've erred on the side of getting additional sections and looking very carefully for viable tumor. But the basic staging rule is if you don't see viable tumor cells, then you really can't use that as assessing your T category, for instance, or whatever category it would affect. So the rule is for pre or post-treatment viable appearing tumor cells. But certainly it would prompt a closer look at that specimen for me.
Okay, here's a question from Ottawa Hospital. In rectal cancer post-neoadjuvant therapy, the number of lymph nodes is usually 6 to 8. Do we still need to find 12?
The answer to that is no. And if you're defining 6 to 8 after neoadjuvant therapy, I think you're doing a good job. And one way I assess how well our residents are doing is the size of the lymph nodes found. If they're finding nodes in the 1 to 2 millimeter category, then I feel much better about them. But the recommendation for for lymph nodes really applies to colon cancer. And we try to do as well in rectal cancer, especially the ones that aren't treated neoadjuvantly. But it's really a quality measure for colon cancer. And it's also affected by patient age. Older patients tend to have fewer lymph nodes, of course, the length of the resection. And for obese patients, it may be very difficult to find those lymph nodes as well. But the answer is no. You're not held to the 12 lymph node minimum for specimens that have been affected by neoadjuvant therapy.
Okay, here's another question. With peritumoral deposits counted separately, will it have an impact on the number of nodes found?
I think it certainly could. It certainly could. Just the short answer.
Another question.
We found a lot of those things. You know, we thought they were lymph nodes, and they turned out to be little irregular deposits next to an artery.
Another question. Is there clinical significance, i.e. treatment implications, for a patient with a sigmoid tumor versus a rectal tumor?
There may be in the pre-treatment. There may be for neoadjuvant treatment. Patients with rectal cancers in our institution, especially if they're deeply invasive, are typically offered neoadjuvant therapy up front. But a sigmoid tumor would not be given pre-op radiation chemo. But for a very high rectal tumor, I think that would be a judgment call on the part of the treating physicians. If it is treated neoadjuvantly, then no, I would think there would not be any ramifications of whether you call it a residual tumor, sigmoid, or rectum, other than irate surgeons, perhaps.
Question from St. Michael's Hospital. If the majority of the tumor is moderately differentiated, but there is a significant area of poorly differentiated tumor, do we assume that the tumor acts as the worst areas or as the majority areas?
I would say in general, if you have an area, a significant part of it, and how we define significant is open to interpretation, that's high grade, but mostly in a moderately diff tumor, I would go with a high grade. I think that is an adverse histologic feature that needs to be reported. So I would go with a high grade in that. And another factor we didn't really discuss because it's not in the checklist is the whole issue of tumor budding. And people may wish to sort of hear a little bit about that. The reason we didn't include tumor budding, which is the formation of small clusters of highly infiltrative tumor at the leading edge of the tumor, the reason that's not included on the CAP checklist is we do not have agreed upon methods to assess that and to sort that into high tumor budding versus low in a reproducible fashion yet. But I think over the next few years, we're going to see some inter-observer agreement and validation studies going out, and that may be something that we want to report in the next iteration of the checklist, especially for stage 2 tumors, in which we're looking for high-risk histologic features for our clinicians to decide whether the patient needs adjuvant therapy or not.
Here's a question from Trillium Health Center, Mississauga. In post-treatment lymph nodes containing mucin only, how many levels do you have to do to rule out mets, i.e., you may find single tumor cells if you do enough levels?
Well, this is a good question. And the guidelines, both AJCC and CAP, really don't require us to do exhaustive searches for tumor cells. So if you're confident that you've seen a good cross-section of the tumor, or a good longitudinal section would be better, then you're not required to do additional studies, either keratins or additional steps to look for those tumor cells.
Another question from St. Michael's Hospital. You commented on mucin pools in lymph nodes not counting in post-therapy cases. If you see mucin pools in lymph nodes in untreated cancers, do you count that as a positive lymph node?
No. Without tumor cells, I would not count it as a positive lymph node. And, there's a literature in breast pathology in particular about so-called benign transport and mucin extrusion into axillary lymph nodes, or dislocation, or whatever you want to call it, not representing nodal disease. And I think that on rare cases you can see similar effects in the colon. Now, whether there are a few tumor cells there and we're just not finding them, or it's some kind of benign transport, I think is open to debate. But without the viable tumor cell, I know it's difficult to make yourself step back from it, but we really, by the rules, should not count those as positive.
And this is a related question from Dr. Sharaf Aldian. When you have a fibrotic lymph node post-neoadjuvant therapy, is it considered a positive node?
No, back to, our underlying rule is without demonstrated tumor cells, we don't call it positive.
Okay, I think we've got through the questions. So I'm just going to make a few closing remarks now. On behalf of the Canadian Partnership Against Cancer and the National Staging Initiative and the Canadian Association of Pathologists, I really want to thank Dr. Kay Washington for a truly comprehensive, informative, and very clear presentation today. This is our fourth and final teleconference in our series of CAP checklist presentations through CPAC. And I'm sure that there are procedural lessons that we could learn for future endeavors, and we would welcome your comments and suggestions. If you could please send those to the following email address, pathology@partnershipagainstcancer.ca. As some of you know, the Canadian Association of Pathologists is actively working to sign a memorandum of understanding with the College of American Pathologists that would see additional Canadian input into the checklist via both the CAP Cancer Committee and also the CAP Protocol Review panels, and those discussions are really underway as we speak. As a reminder, both the live and recorded presentations are eligible for continuing education credits. The evaluation form for this presentation was previously distributed. Please return the electronically completed evaluation forms to pathology@partnershipagainstcancer.ca in order to claim your educational credits. Once the WebEx recording of this presentation becomes available, it will be made available for wide distribution via the membership of the Partnership's National Pathology Staging Committee and the Canadian Association of Pathologists. Access to this recording will be available for review at your convenience and is not restricted. Finally, I'd like to thank the members of the Partnership's National Pathology Staging Standards Committee, for their valuable time and assistance in making this event successful. While there's no more formal CPAC presentations like this, there is a plan for Cancer Care Ontario to continue some of this work and look at some of the other high-volume checklists, the new 2010 checklist, and we will keep you posted as to how that develops. And certainly these will be made available for the national audience as well. So once again, I thank you for your attendance, and I call this meeting to closure.